to the stage to give a brief about the program and facilitate its formal launch. Yeah. After this, yeah. to start taking your seats. We will begin in 5 minutes. Request you all to please take your seats. Okay. Good morning, everyone. Sure. Request you all to please take your seats. Yeah. Good morning and a very warm welcome to you all. We're delighted to have you join us for what promises to be an engaging and fruitful discussion on scaling digital innovations in public health for impact. This event marks the beginning of an incredible 5 year journey by PATH and the Center for Cellular and Molecular Platforms to support and fast track the demonstration, adoption, and scale up of market ready digital health solutions to address the pressing needs of health systems. Recognizing the potential of technology to achieve the Sustainable Development Goals, the program seeks to create an ecosystem that supports evidence based digital interventions for sustainable impact. On behalf of PATH and CCAMP, I'd like to thank you all for joining us today. To felicitate our dignitaries, including speakers, panelists, and moderators, we have pledged plantations of approximately 50 trees at Sundarbans National Park, West Bengal, under the project Trees for Tigers by planttrees.com. So we'll begin our thank you. We begin our day with the plenary session. I'd like to invite our esteemed guests to the stage. Neeraj Jain, Country Director, India, and Director, South Asia, PATH. Dr. Tasleem Arif Saeed, CEO and Director of CCAMP. Shri Vishal Chauhan. No, we will also be joined by Shri Vishal Chauhan, Joint Secretary, Ministry of Health and Family Welfare, as well as Major General Dr. Atul Kotwal, Executive Director, National Health Systems Resource Center, shortly for a special address. Okay, thank you. I'd like to request Neeraj to please come to the podium and deliver the welcome address.
Thanks a ton, Anand. It was feeling a bit strange sitting so far away from Tasleem with two empty chairs. But hopefully, Mr. Chauhan and Dr. Kotwal will be here very soon. I just want to thank you all for coming here this morning and a very, very warm welcome. I know some of you have come from overseas, some of you have come from far away. Bangalore, Tasleem, thank you for coming. I was telling our team just yesterday I said Tasleem has only arrived when he arrives. So be careful. Just make sure he's coming. So, thank you for coming. I think the presence of all of you is absolutely critical for us for this program to be successful. The program is not between PATH and CCAMP. The program is to provide a platform which all of you can access, or everybody out there, to look at digital solutions that are actually going to make impact on the ground. India has seen major digital transformation. There are a lot of digital public goods that are coming out of India. And that's also, if you think about where we were 5 years ago to where we are today, that change of digital health and the work that's happening is absolutely fantastic. The India stack has been a great sort of a beacon for us because with the set of open APIs, they've helped us to get Aadhaar on the ground. I mean, one of the world's largest identity programs, the UPI, which I think we all are aware of. And this has really helped to show how digital can actually be an inclusive tool for low middle income countries where populations are really fragmented and all over the country. As COVID swept across the globe, routine health service delivery came to a standstill. Health services like immunization, antenatal care, etc., were really affected, and the vulnerable populations had no access to healthcare at that point. We're all we've all seen that happen. 2 years of huge challenges. Having said that, this is where I think technology really played a significant role for us to absolutely reach the unreached, those who were disconnected from the health systems, and ensure quality delivery at scale. Digital interventions like telemedicine, I've been in the sector for about 7 years in Path, and telemedicine was practically negligible apart from a few pilots. But we just saw that take off, and the entire country is now connected using telemedicine, and it has really increased the reach of health services across the nation. If we didn't have it, the impact of COVID could have been much more catastrophic. The pandemic also thus provided us with an impetus to the already expanding digital infrastructure in the country. It created an environment that was conducive. It created a need. It created a desperation that we need to build this very quickly. We saw Arogya Setu coming up, absolutely, pretty much, I would call it overnight, considering how things used to operate before COVID. CoWIN, another big one. And we talked about telehealth, eSanjeevani, absolutely fantastic programs that the government of India scaled up. I remember landing in Ladakh during COVID or just in between, and we went into we were clearing security, and I had an American friend with me, and the security lady asked us to show our vaccination certificates. Of course, I took out my phone. I was able to quickly show my certificate, and my friend opened his wallet. He had a little piece of paper which he had folded and stuck inside. That was his COVID certificate from the US. And he showed it to the lady, and she said, no, 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 I don't need this. I need your COVID vaccination certificate. So it took us about 10 minutes to convince her that this was a COVID vaccination certificate, non digital, but so, India kind of showed the way to the world in terms of how it could be done. In 2022, the global digital health market was valued at about $200 billion globally. And also, the growth is expected to be about 18% from 23 to 2030. So, huge amount of growth that's going to happen in this space. There's also large investments that are going to happen in this digital health space. The private sector is going to play an important part, but of course, public health is not far behind. We've seen the ABDM or Ayushman Bharat Digital Mission ecosystem come up in front of us. There's been a huge amount of work in terms of innovative solutions. We've seen some great solutions coming out there. Of course, there are also many that probably cannot be scaled up, many that probably are going to, fall on the wayside, but lots of great solutions out there. And not only for medical care and point of care devices, but also systemic digital based systems like citizen facing applications, digital health lockers, um, On consent frameworks, another big area of work, system integrators, etc. The whole idea of us getting together is to try and foster co-creation, leverage innovation, and really have a shared commitment to improving healthcare delivery. So Path and CCAM have got together to try and deliver on some of this vision. And the idea is to create an ecosystem. The idea is not for us to run a program and talk to you all about it. The idea is to create an ecosystem, and we want all of you to be a part of this ecosystem, to work together to try and build that. We want to make sure that it has widespread impact. We want it to be sustainable. We want to focus on health outcomes. That's going to be really the beginning of our journey. So today, thank you all for joining us. We are marking the commencement of this journey. And I'm very, very confident that our efforts, collective efforts of all of us, including all of you sitting out there in the audience, will have a positive impact, not just in India, but all over the world. Thank you so much for coming, and I hope you enjoy the morning. We decided to keep it short so that we've seen that post-lunch sessions are normally pretty empty. So we are hoping that you'll stay till lunch, and that's where the program will end. Thank you so much. Thank you.
Thank you, Neeraj, for setting the stage for the rest of the day and reiterating the importance of fostering actionable collaboration to improve healthcare delivery for all. I now welcome Dr. Tasleem Arif Saeed to the podium to set the context for this transformative journey we're about to forge in the coming years.
Uh, Good morning, everyone. And absolutely a pleasure to be with you all for this very exciting journey that we are all here to, be a part of together broadly. Uh, we have, uh, a very important first half of the day that we hope to, build a dialogue together with you in terms of what we broadly aim to do together, how what we want to do it in terms of taking digital innovations to the next scale. But if I may quickly and briefly possibly talk about it, I can't help but 100% agree with uh, Neeraj in terms of this is not a program, but this is actually a platform. He used another word which I'm going to shamelessly also copy again. It's an ecosystem for a larger impact. And why larger impact? Because any potential needs to be realized. And we have been talking about potential for years together. Building new things, building new innovations. When do actually those innovations become really, really impactful at scale for for the large country that we have and beyond? When you actually make those impactful on the ground, and the program is attempt to bring all stakeholders together, work and ensure that those innovations, which are not only globally relevant and but also contextual to Indian settings, which is very, very important, and how that goes forward. The program is an attempt, a very ambitious attempt, if I may say so, to come together and build that thing. And we really invite you all to become a part of it. Already, our networking meetings, I have requested few of them to come together and become a part of it, and hope after that we'll be able to do that. So, if I may just quickly say, and I'm borrowing some of the context, I'm not as fluent speaker as Neeraj, so I'm actually relying on some slides here, but try to get the message home. If you see here, and the logos are quite small, digital health has huge impact across many areas of healthcare delivery. It's very transformative in nature. This is a global top 150 companies which possibly were positioned to transform that. Good thing, even in 2019-20, we had a few companies there. As years are passing, we are actually entering more and more companies in this number and making it over. So we are on the dot. We do know about our healthcare challenges very clearly. Our challenges are very clear. We have a very large population to look at. We have a very tight cost constraints that we actually work with. We do know about that. We have a limitation in terms of skilled human resources. and we have a population which is spread across different geography, different resource setting in many other parts. It's not actually a very static way. It's a very, very, heterogeneous geographical setting as well. So now we have to do well for possibly 20, 30, or 40% of our population, which is not getting the best public health coupled together. So what is that we can do it in, building it together? India, as Neeraj said, is already on a rise in terms of building in digital tools for many things. It is at the cusp of digital revolution. We know about it. There are reasons. I don't need to really reiterate those reasons. The last decade already saw the new ways which have come in across many things, including COVID, e-Sanjeevani, health tech, and so on. Government of India has been a huge catalyst, huge, which has been driving many things. It's allowing things to happen. That's a great way to, build an open innovation digital program. And we have a phenomenal large talent pool. So for India, digital technology is not an aspiration. It is a necessity based on what we have seen in the healthcare challenge. It is absolutely got to do it. And then if you got to do it, why don't we do it with ambitious scale? Why don't we do it and then deliver it together? Because that's what the large impact will need in terms of the what we look to do it, and what we at CCAM look to do it as well, along with Path here, is to we do know about what happened and how digital technologies got accepted, got adopted in COVID times. We had a large population. That means we have a large opportunities. At the same time, the challenges that I mentioned are broad enough. So, at any promising technology which has a broader capabilities in terms of taking it to the next level for healthcare delivery, not only has a market in India, it has a global market in a way. We can actually, many of us can do it. For an example, the diagnostics program that we ran with many collaborators, not only India became the one of the highest production of RT-PCR per day in terms of capacity, we also built most affordable RT-PCR kit from India, which have been then gone to other LMIC and supported. It's a clear example of that when we actually deliver something here, many countries will actually have opportunity to adopt it and take it forward. So there's a global play as well built into it. So together, what we hope to do is to take this opportunity and the promise, the digital innovations that actually present to us and scale it up, not only take them to a few early stage of deployment, but scale it up, integrate with public health systems across states, and then provide opportunity to take them beyond as well, including LMICs. So we're very excited to build this collaboration together. And if I may, and this may not be readable from far, but what we hope to do in three quick layers is to identify critical gaps in public health settings by working with central and state government settings, build and empower and enable the high impact innovations which are contextual, integrate them as my colleague from before me said, build evidence which actually convince everyone, all stakeholders, to adopt it at scale and take it to the next level. And of course, develop a large program and template that can be scaled and systematically integrated. So we are very excited that something like this we are beginning. And what I would like to believe is that friends who are there in the room and beyond, we can actually make it happen through a potential collaboration that we hope to do with you. And there are many ways this can happen. If I may just say that the impact of it is very transformative. It is not only healthcare, because when you actually deliver a good public health for your population, there are many other impact that happen in terms of developed society and a progressive society. It goes beyond healthcare. And digital health tools allow us to bring the public health much beyond that what is it today, and we can actually make it happen in terms of equity, gender equality, and many other resource setting which are built in. So I am very, very excited that we have taken this collaboration today, and we are hoping that many more partners will come in. I met many of you today before in the networking, but I hope that we can build it more. And before I close, I must congratulate the team from Path who has actually done very hard work in building together, and my colleagues at CCAM who have actually contributed in that as well. Thank you so much, and looking forward to build this together.
Thank you, Dr. Saeed, for outlining the larger vision for the platform and what it aims to achieve by leveraging key partnerships. Our next esteemed speaker, Sri Lava Agarwal, Additional Secretary, Ministry of Health and Family Welfare, couldn't join us today in person due to another important engagement. However, he has shared his keynote address on the journey of digital in India and why now is the right time for scaling digital innovations via video message. So I invite you now to watch that.
Mr. Neeraj Jain, Mr. Syed, and all the distinguished delegates. At the outset, I would like to thank ARC and CCAM for inviting me for this event towards scaling digital health innovation. Friends, I have had the opportunity to closely observe multiple global digital health initiatives which were very immaculately planned and executed, but they remained limited in purpose and had little scalability. In this ambitious journey of technology transition, we're passing through an epidemic of pilots in the digital health space. India has made exceptional progress in digital healthcare delivery and has demonstrated full use of digital health in major national health programs such as Hospital Information System, Online Registration System, Nikshay for managing TB cases, Mother and Child Tracking Program, Health Management Information System, Integrated Health Information Platform, a platform for non-communicable diseases, and many more, which have benefited patients with timely service delivery and making government healthcare more affordable and accessible. However, it is also felt that all these efforts need to converge into a singular framework to achieve interoperability of data, which would benefit both policymakers for decision making and patients with effective services allowing for continuum of care. With the prime principles capture data once and used many times and moving from silos to systems. Government of India released National Digital Health Blueprint as an architectural framework for effective implementation of digital health intervention. Continuing with India's dedicated efforts towards establishing a holistic, comprehensive, and integrated digital health ecosystem, India launched nationwide implementation of Ayushman Bharat Digital Mission with an aim to develop the backbone necessary to support the integrated digital health infrastructure of the country. Friends, let me give you some examples that how a scalable solution can be a game changer even for a country with 1.4 billion population. During the COVID-19 pandemic, India had set an example for world by developing quick to deploy, customizable, fit for purpose, and scalable solutions like CoWIN and eSanjeevani application. CoWIN application ensured that we are able to monitor the administration of more than 2.2 billion vaccine doses and have now recently been augmented to cover all immunization activities under the umbrella of Universal Immunization Program in India. I am happy to share that it is now being piloted in 65 districts of India and acting as a single source of information for immunization services, updating vaccination status, delivery outcomes, planning of routine immunization sessions, and for multiple reports to all stakeholders. Similarly, India has indigenously developed and deployed eSanjeevani application during COVID, which is now the world's largest free of cost online national telemedicine service and has already rendered more than 14 crore teleconsultation and covering 95% population of India. It is presently conducting around 4.5 lakh teleconsultations a day. Friends, with such developments in digital health, India has leapfrogged in terms of the adoption of digital health in the public sector. It is creating a digital health ecosystem through wide-scale adoption of digital tools across the continuum of care. Recognizing the transformative potential of technology in healthcare, India has taken up proactive steps to harness digital innovation, promote healthcare accessibility, and drive advancements in the field globally. On in the digital health journey, India introduced the World Health Assembly resolution on digital health at its 71st session in 2018 in Geneva which was successfully adopted by member countries and has spurred global action on this vital agenda. India has led the Global Digital Health Partnership, which is one of the world's largest intergovernmental and multilateral forum on digital health, having 36 member countries and 3 international organizations. Colleagues, now, as the president of G20, India has further identified digital health as one of its key health priorities, namely digital health innovation and solutions to aid universal health coverage and improve healthcare service delivery. Under this priority, we propose the Global Initiative on Digital Health as an institutional framework for the development of global digital health ecosystem. It intends to create a platform to converge global efforts on the agenda and build consensus on the promotion of digital public goods by enabling customization and democratization of technology through these digital public goods. We could address challenges in universalization of digital health and bridge the digital divide by promoting equal access to technological tools aligned with country needs. These solutions can exponentially boost the adoption of technology for healthcare service delivery by cutting down the time and resources required for their implementation. Adopting an action oriented approach for its G20 presidency, India successfully steered the global effort in the direction of tangible outcomes, and as a result of the same, we are able to get the alignment of G20 countries toward global initiative on digital health as a WHO managed network. I am glad that this collaboration between PATH and CCAM will further add to building consensus and action towards sustainable and scaling up of those innovations which are customizable and interoperable digital products. I hope that this joint initiative of PATH and CCAM will create required synergies amongst different stakeholders for developing comprehensive, scalable, and integrated digital healthcare delivery models. We know that we are all collectively on a momentous journey. World is seeing the fruits of technology aiding to the service delivery, and we need to collectively work towards ensuring that we make an impact in terms of making our primary health centers, making our second and tertiary delivery services efficient, accessible, and affordable to all. Thank you.
Thank you, sir, for reflecting on the journey India has taken in fostering digital health innovations to address barriers to affordable and accessible healthcare and spotlighting the importance of citizen centric approaches to building resilience. I now invite our next esteemed speaker of the day, Shri Vishal Chauhan, Joint Secretary, Ministry of Health and Family Welfare, Government of India, to deliver the first special address of the day. Please join me in welcoming him.
Mr. Saeed, Director for the CCAMP, Mr. Neeraj Jain, Country Director, PATH. Uh, I can see team from NHSRC, uh, our partners, development partners, innovators, those who are in the field of digital health or in the IT. Thank you very much, first of all, for inviting me for this event. And I am very happy that CCAMP and PATH are launching a program by the name of Scaling Digital Innovations in the Public Health for Impact. There has been a lot of progress, lot of sea change as far as our approach to the digital health is concerned. If we see historically, we had you name a program, we had a portal in the government sector for that program. And for 10 years, we keep on struggling because as all the portals in the government programs collected too much of data uncalled for, and they were slow in responding. They were all working in silos, not interacting with each other. And also the reach was, best of the programs were used by 60, 50, 60% of the desired healthcare workers, and some remain restricted only to the 20% of the healthcare workers. So there has been lot of issues as far as the government digital health products are concerned or programs are concerned. And but in the last 1 year, very significant progress has taken place. We Government of India launched National Digital Health Mission, and it created an ecosystem for digital health. And after this, we and especially as we Mr. Lavagarwal was talking about CoWIN platform. CoWIN has been a tremendous success. And why it has been success? Because gave us a very strong message that best things are the most simple things. CoWIN is successful because it asks only 3 4 data sets for every individual. Very simple to use. Unfortunately, in our government portals, most of the time we are, as I said, collecting too much of data. So that is why now this has been a big learning, sea change in our approach as well as we approach the various digital portals. Now, as I said, if we have 50 programs, we have 50 digital portals for each of the program. Now, what has changed in the last 1 year is that with the ABDM ecosystem, now every citizen of the country is going to have a Aadhaar ID. Every facility will have a facility registration number, and every healthcare provider will have a healthcare will have a registration and a unique ID. So it has really going to help us in linking all the programs. Now we have a typical requirement of the government portals when we talk of that, uh, we need the name of the ward also, we need the name of the village also, we need name of the PSCs also, we need the name of the sub center also. And because rural development want data village wise, Panchayat Raj department want data panchayat wise. There will be some other department, there will be a women and child welfare department which will ask data like how many women got benefited. So of course that gender is important. So what is happening is that we collect too much of data. On the other side, we have lot of fantastic apps created by private sector developers, innovators, and which does not have these kind of requirements and very comfortably, very user friendly manner used by the urban, mostly by the urban citizens. These are private apps, useful. They are health apps serving the various purposes. They are used. Now probably a time has come that there is a learning from both sides. There has to be marriage between both the approaches. There will be some requirement for the government side, but as I'm saying, the experience from the COVID is that we have to make all digital apps very user friendly and easy to use for the health care workers, and we get reports in a very quick and faster manner. Now, how do we do it? Because you as all the audience sitting here will be interested to know what is the role for us. Will the government continues to work in their own fashion? All the apps continue to be developed by the NICs, and and we keep on struggling. So I want to tell you that now there has been a complete change in our approach. We are encouraging and inviting each and everybody to work in the sector, do their innovations. We have a national innovation portal maintained in the NHSRC. So whatever you work in the field, you develop in the field, please show us some result, some pilot that this is the way we have done it, how it is helping the program. So if that is done, we'll be very happy to do a pilot testing in a government setup, and we'll try to add those things in our program so that our programs make very effective. I give you some examples like NIPI in J&K have done developed a portal and a mechanism where a self-assessment of the health facilities is done, whether the facility is a IPHS compliant or not. And very happily we listened to them, we understood what is it is doing, some little bit changes we suggested to them, and now I'm very happy to tell you that now it is part of the national program. We are developing little bit meeting the government requirement, and we are rolling out to the all the countries. Dell has been working with us on the national NCD portal. After that, we requested Japaigo also to help us, and with their partners, the speed of work has increased tremendously. So I invite everybody to work in, but only thing is that you have to be updated like what we are doing, because somebody approached me, sir, we have made a app on the sickle cell, but I said we have already made it. So and it was no different. So my only request will be, please see whatever we have done or already doing it, and please give us a solution which will bring add value to it, and we'll be very happy to adopt that, so that it is a win-win for both of us. So that is going to be our approach. I hope that three priority areas have been selected here. I think one is on reducing neonatal mortality. Then second is innovation to reduce IMR and MMR. These are SDG goals, but there are other SDG goals are also there, like reducing mortality by one third due to the non-communicable diseases, and there are many others also. So I will request that you work in these three priority areas, but work in some other areas also. And we are very happy to work, any one of you, everybody with you. If you bring us some innovation, some value addition, we'll be very happy to include in our programs. And and that integration is always now also we are working, that our healthcare workers have to use, as I said, multiple portals. So now UP has made a e-Kavach where one ANM can use one portal and all the programs are available in that portal. Now for CHOs also we are trying to create a portal. So similarly, opportunities are immense, and I welcome everybody. I congratulate Path and CMAP for taking this initiative. I want to assure you that from our side, you'll get full support, cooperation. Please provide us some solution, innovative solutions. We'll be very happy to incorporate it in the national program. Thank you very much.
Thank you so much, sir. I would like to thank our esteemed speakers once again for their insights, which will guide I was going to say project, but platform going forward. I request you all to remain seated, however, as I now invite Sameer Kanwar, Director, Digital Health, India and South Asia, PATH, and Niranjan Joshi, Platform Program Lead, Digital Health and Innovation Deployment, CCAMP, to the stage to give a brief about the platform and facilitate its formal launch.
Dignitaries on the dais, ladies and gentlemen, a very cold and a very cold good morning to you, because I think the AC is probably working working uh, on a very lower temperature. We are trying to get it adjusted, so please bear with us and apologies for that. Uh, I would like to start with a confession. When we actually embarked on co-creating this program, that is Path in CCAM, we thought we understand public health, we understand scale, and we understand impact, and we also work in the space of innovations and digital. So we'll be able to wrap it up in about a couple of weeks. Unfortunately or fortunately, it took us 6 months, to get this design up for the program. Because when we actually started deep diving, we understood that there are a lot of complexities. All right, and we are extremely grateful to Shri Vishal Chauhan for being so candid and opening up this platform. I think there could not have been a better start for the platform to get a government buy-in at the initial stage itself, and that reflects on the way things have actually changed in India. Right. Neeraj talked about the ecosystem, and that actually sits at the bedrock of this program. And it gets inspired, from a document with Mr. Love Agarwal mentioned, that is the National Digital Health Blueprint, which talks about, a transition from a system to an ecosystem approach. Right. And that's where we want to shift from using systems and innovations in siloed into
a more ecosystem integrated or an interoperable. Rather than using a word integrated, we would like to use the word interoperable, because integration, I think, is past. It is now making them interoperable, making them talk to each other, right? And how do we enable an environment which can provide a platform wherein innovations, wherein digital technologies can come in? And if I may also use a bold and provocative statement to say that, in health, digital as well as innovations, for digital and innovations, it has been a graveyard of pilots, right? And therefore, we want to come out of that, right? We want to create an ecosystem where applications can be scaled, they can be sustained, and in case required for sustainability, can be transitioned either to the government or to any other stakeholder who is willing to take those innovations ahead, right? We are also looking at an opportunity uh, to create a platform where India can actually be taken to the globe, right? We talked about, Mr. Love Agarwal talked about so many innovations. Neeraj talked about the DPIs, and Tasleem talked about, the Aadhars and the UPIs, right? So all these are innovations which are very close to India, which are setting up a platform or again an ecosystem of digital public infrastructure which needs to be taken to the globe for other countries. So that's the end game for this program, and hopefully, I think we should be able to reach that. I will just quickly flash two slides, largely which look at the vision, which we've already covered in terms of, the keywords are ecosystem, it is scale, it is sustainability, and it is impact, right? And the principles, and I'm grateful to Tasleem for that. He's already covered, in terms of being able to identify those critical gaps. And what Shri Vishal Chauhan ji mentioned, I think we are extremely happy because once we launch this program and we have more details, you will see that, it is in sync with what he was talking about in terms of reducing those SDG goals and achieving those SDG goals in the coming year. How can we support that through technology and through innovations? We are also looking at empowering, the high impact innovations, and how do these innovations come together to be able to deliver for impact. And the third, of course, like I mentioned, that we are looking at, looking at developing a comprehensive and integrated digital care delivery model, a model which can be scaled as a model which can be adopted by other LMIC countries and can go to other countries in the world. So it's a model which we are looking at. We are not looking at individual innovations and individual digital solutions to be taken, but as a model. How does that process re-engineering and process engineering, which is required to get this system up, also gets transitioned as part of the innovations? And then only can we look at scale and sustainability. I will now hand over to my esteemed friend and co-creator in this initiative, Niranjan, who will now talk about as to what is the approach which we are going to adopt and how are we seeing the outputs and the outcomes in the next 5 years. It's a 5-year program which we talked about, under which we are looking at a couple of projects coming in, and he'll talk more about that. Over to you, Niranjan. Thank you.
Um, thank you, Samir. I think it's been a wonderful first session listening to all of the esteemed speakers here. It's also very heartening to see government's approach, very positive approach, something which is very important, especially in the health health domain. And I think that's a very positive start for us. I'm just going to delve quickly into the strategic approach that we are going to take here for this platform. Path and CCAMP, we will identify 2 or 3 projects that is to begin with. But what is more important here is that we are looking at a public health use case, specific use case. And when I say public health use case, this is not about a technology. This is not about digital health solution. When it comes to the public health, and we have often spoken with many of the experts, they say that we need, I mean, there is a continuum of care. This is not just one specific application and one technology. This is not your agenda. This is public health's agenda. This is the agenda of the health system, how to solve the larger goals, whether it is MMR, IMR, or any other one-third reduction in the mortality due to NCD. This requires concerted effort. There is a continuum of care, and there is probably tens of technologies that are going to go together. They have to work in tandem together. So I just wanted to emphasize that point, that when I say public health use case, we are looking at not just the scale of the geography and saturating the geography, but it is also the scale of the number of solutions that we are going to put together, and ensuring that they are working in synchronization together to deliver that public health use case. So that is one important distinctive discussion. And Samir mentioned that we we could probably come to the drawing board, whiteboard, and do the set of things. Uh, but it took us a long time, mainly because of that. We have our esteemed speaker here joining together. Samir, do you want to interrupt? Okay. So, so that is one important thing that we are looking at. What we have definitely is a large set of a large pool of digital innovations that are there in CCAMP and PATH's ecosystem. Once we have identified the public health use case, we will map the solutions with the use case, with the continuum of care use case, and then we will go out in the project mode. So that's the way we are looking at. Once we have a success, the evidence that we have shown on one public health or two or three projects, public health use cases, we definitely have the aspirations to go global. So that's one thing that very clear about. Quickly, in terms of the outcomes, I have already spoken about it. It's about the continuum of care. It's about the saturation of geography. And it's also, more importantly, can we get digital public goods? Can we get out a set of technologies that really can serve the society at large, not just in India, but across the globe in the LMICs? But we always know that whatever works in the LMICs is definitely is going to work in all the other countries as well. So we are not saying that DPGs are just for the LMICs; it is for the world. So that's what we are looking at. I will take a pause here now. Thanks, Samir. Thanks to PATH, CCAMP, for putting this together, giving us opportunity to put this together, and we hope to have this continued support for the program. Thank you.
Thank you so much, Niranjan and Samir. I now invite esteemed speaker, Major General Dr. Atul Kotwal, Executive Director, National Health Systems Resource Center, to deliver a final special address of the day, Digital Transformation of Health Systems, Leveraging New Age Innovations for Public Health Impact. Please welcome me and join in inviting him.
No problem. Good morning, everyone. You can't refuse an invitation from Mr. Neeraj Jain ever. That's uh, Shri Vishal Chauhan, Joint Secretary Policy, Ministry of Health, Mr. Neeraj Jain, dignitary on the stage, dignitaries of the dais, and all the participants. It gives me immense pleasure to be here. There was another meeting on non-communicable diseases organized by AIIMS Jodhpur and NHFW and HSRC combined. That's why I had to be there in the morning, and I'll rush back from here to join them subsequently. So I'll just share a few thoughts. I was asked to speak on, the topic was given to me: digital transformation of health systems, leveraging new age innovation for public health impact. A large, long topic, but I think I'll start with a quote of Charles Darwin, who said that it's not the strongest of the species that survives, not the most intelligent, but the one most responsive to change. I think that I think sets the context of the entire, I think, the workshop today. And digital health and innovations have played a significant role, which I think you all are aware. I don't need to, list out what all has been done, what all has been achieved. And the in clinical care, you all know the importance of digital health in diagnosis as well as the management. Now there's a personalized medicine also which is coming up, even in the research field also. And in public health, we all know, to improve the health system as such, reducing the out-of-pocket expenditure, where the teleconsultation has clearly shown the amount reduced per visit also, and reduce catastrophic expenditure on health, improve the quality of care, increase patient satisfaction, and providing these specialist so-called services which were not beyond the reach of many people within their grasp as such, with the various innovations as such. And but it is important to further deliberate on how to the move ahead. I've tried to list out 9 important points which I meant which I would share with you. How not now to expand the use of digital technologies for communities, how to maximize the opportunities for digital transformation of healthcare, how to ensure universal connectivity, how to be make it inclusive, digital health addressing equity for all concerned, the users as well as the community. The digital health interventions to now to be become common goods for health, the like digital public goods. And Mr. Neeraj Jain has written 2 3 good articles, short articles on LinkedIn, and the very well written articles. So the common goods for health, which you all are aware, like under the PM Abhim and Finance Commission and all the critical care blocks, public health units, these are common goods for health. There's no competition from the private. Private is not interested in creating all these for the government system as such. So that's where we must commend the current leadership of the country also to have thought of these instead of only the looking at the conventional way of healthcare delivery as such. The confidentiality and data policy is another important issue. The ethics of entire when we talk of digital health, human rights, and also the most important, last but not the least, I think one of the most important, the ninth one is the appropriate use of artificial intelligence in health. A lot is being done all over the world, but what are the data bases for the artificial intelligence? And I mean, there's a lot to discuss on that. I'll leave it right now for here only. So how digital health you helped us in the during COVID management? You all are aware. I'm not going into details here, but I must share that that's the first time someone like me who's been involved in research and all since several years use SurveyMonkey in the. Sorry, we rushed you. Thank you, thank you so much. Thank you. Used the this thing. I'll just hold. No time to blame that. That's fine. So we use that, and in the March and April of 2020. But that time only 36% of the households in the country had smartphones. So inherently, all the surveys done in 2020 were flawed, not only by us, even by everyone else, because they were all using these IT tools as such, because the people are unable to go door to door for hard copies of the or even whatever data collection technology techniques as such. Currently, of course, it has crossed 75% of the households in 2022-23, and the penetration is increasing. But that's another point which I want to highlight is that when we talk of utilizing this technology, the biases and all should not come in as such, and that's why there was an infodemic in COVID, which we all had to address wherever we were in whatever capacity we were. And the progress for COVID as such, that's been a huge success, and I think we must applaud the people who are all involved in this. And before that, no one could ever think of that this kind of system of vaccine distribution and also vaccine management, appointments and all could run so smoothly and flawlessly, which is a learning for several countries in the world. So we have come a long way, and COVID has been a an accelerator for the digital technologies as such. The collaboration as such, as we all are aware. So I'm told this collaboration today between PATH and CCMP is on scaling digital innovation in public health of impact. And I think this workshop is the right time, because this project envisages promoting the adoption and acceleration of technology-driven needs, leveraging digital solutions to enhance the quality of care and improve larger health outcomes. So more importantly, I think it promises to scale up successful innovations to comply as digital public health goods. Please add on if I've missed on something. And the digital public goods we all are aware, which we know, So that brings us to digital health services as such. What are the digital health interventions, digital health services, which use information and communication technologies to improve all aspects. We should not only be looking at one. So it's preventive, promotive, curative, diagnostics, uh, even palliative and rehabilitative also. All these should be addressed by the digital health goods as such and be part of the healthcare delivery. There have been, when we talk of a newer thing and when we talk of innovations, there are several enablers and barriers always. There are conventionally, we all know what are the enablers and barriers. There have been few research papers in recent past which have tried to look at enablers, barriers in the field of digital health intervention and the innovations as such. One of the papers, listed 36 enablers and 33 barriers. But as we all are aware that I think they are same as per the conventional ones. The leadership, culture, interdisciplinary correlation, co-creation, innovation characteristics, and methodology. These are all part of the earlier ones too. And but we need to list these, lest we forget that we need to address all these the barriers and leverage the enablers. So poor leadership in projects always hinders the scale up of DHIs. The lack of interdisciplinary co-creation, and there are certain unique characteristics of each innovation which may act as barriers. But if you are able to integrate that into the entire system, will act as enablers also. Lack of trust when transferring a technology from one region to another that's not been created here, that's another potential barrier which needs to be addressed. And even the pace with which one is changing, that also needs to be looked at, whether to use it to our advantage, how to use it. And of course, getting all stakeholders on ground on together as such in a dialogue and engagement, that's another important enabler. And in stakeholders, we should not forget the community and human resource for health ever, instead of we all sitting here and discussing about it and talking about it as always. The Government of India's initiatives, again, very well known but worth mentioning. The Ayushman Bharat pillars, four pillars, you all are aware. The ABDM as such, which is looking at the technology, creating the health stack. The health and wellness centers, how they are leveraging technology, teleconsultations, 14 odd crores plus teleconsultations to date, out of which 13.3 crores are through the health and wellness centers. But people sitting in remote areas are able to access the medical officer or specialist now, which was not possible earlier as such. But the another is HMIS and all, data management, electronic health records. We all are aware. But as someone famously said last year, sometime I think someone made the statement, which I recollect, not exact words, but the EHR will be a thing of past. I think another year or so, when we have Aadhaar IDs and personalized health records. Everyone will have their own record as such, which are available to everyone as such on a rights base. So the HMIS of the hospitals, which we need to strengthen, and I'll come to a few challenges and all, and what is happening on ground as such. The uh, the policies and procedures have already been there under the ABDM, which you all are aware. Coming to the innovations, the Government of India is encouraging scaling of appropriate and effective innovations. And but then again, when we talk of innovations, there is no use for our efforts for digital health interventions or even innovations if we don't ensure accessibility, availability, affordability, applicability for that particular community as such, and also the quality services. So these aspects need to be looked at, including the improved responsiveness of the health system, because anything when we add digital, it should enhance the responsiveness of the system as compared to what is happening currently. The enhancing the autonomy of the healthcare choices by the people, improving public participation, and also we should not restrict ourselves to health only. Look at the social determinants of health also. When we talk of digital health intervention, that it's time we include the digital interventions of social determinants of health also as part of digital health intervention bouquet as such. In NHSRC, we have a National Health Innovation Portal, which we have improved tremendously. We'll shortly open it for submission once we get the approval from the Ministry of Health. And it has two parts: the best practices by the states and also the innovations, including digital innovations by everyone. It will be open to all. I think Dr. Ranjan will be speaking about it in the length subsequently. We have also now working with states now this about state innovation hubs. We had a national workshop in April 2023, and now each state has been given the option to create state innovation hubs embedded within the state health system resource centers, where dedicated funding would be available to them to look at these innovations from very beginning, look at the methodology, the evidence base, and then see whether they are replicable and could be upscaled subsequently if found fit for the health system. And we, of course, also support the MHFW in piloting and scaling up innovations. And so there's a felt need to systematically identify high impact innovations to address health indicators, mortality, and morbidity. But then, nothing of this, whatever we are discussing here, sitting here today, all the DHIs and and all initiatives, and nothing comes without the challenges. So I would just like to list out few challenges. The number one is issue of data management and cyber security, which I think we all need to list out. The policies have to be very, very clear. The governance and enforcement of policies and regulations, because we talk of stakeholdership, we talk of involving all the NGOs, development partners, private players, and all, and the community as such is there. The government of India is there. So what kind of the policies and regulations are there? How to expand the reach of digital health interventions, the scaling up, and of course increase uptake by the people and acceptability by the people. Sustainability of these DHIs. So they will sustainable only when they are acceptable as such to the community. The issues pertaining to ethics, that's because a lot of data would be available not only for the common use as such, again for research purposes also. So we need to have this ethics policies very clear. By human resources for health, currently the time consumed by them, so 45% of the time they're consuming in maintaining data, hard copies as well as digital. When they move to digital, there has to be that single sign and single sign off. And I must commend the Joint Secretary Policy sitting here, Shri Vishal Chauhan ji, for this initiative now for single sign and single off sign off, where we're trying to integrate all these portals together. And the HMIS, again, when we visit the states, each state has its own HMIS. Within the hospitals, the HMIS is not interlinked within the department. There's no intra-hospital linkage also. And there's one chap who's operating it, and he says ki once the initial patient registration is done, then the information goes to the doctor who scribbles on a pad. That then with that purchase, patient goes to the dispensary, and then the pharmacy chap gives the medicines, and the evening he enters the data into that. So that's a kind of HMIS which I think is very archaic kind of system, but the funds are being utilized for that. So how to work with the states and these institutions to create good quality HMIS. And ABDM, again, the how to now integrate all these. There are too many portals and too many applications. How to integrate all these, they talk to each other, and that will give the confidence to healthcare workers as well as the community also, that once data has been entered, it should be available seamlessly to all the others applications also. But then the opportunities are there. The research for promoting locally and contextually relevant innovations or innovative solutions, but then again, all these solutions should be linked with each other, and portability also has to be ensured. Engaging the community and human resource for health, I've already mentioned earlier, but we need to engage with them more to address their concerns and address their priorities, and how to scale these up. The referral mechanisms through technology. We are talking of continuum of care, but we have not leveraged technology as such for referral mechanisms and continuum of care. It's only teleconsultations, but again, referral and follow up during the admissions and subsequently coming to the community. And again, referral up in case required. How to leverage technology for that? I think we are way behind in that. Tackling emerging issues like climate change, disaster, migrations, One Health, and emerging re-emerging diseases through DHIs, and also the AI, as I mentioned earlier. That's another opportunity to create evidence-based data which could be utilized in AI for appropriate diagnostics and management as such. Just quick on way forward. I'll wrap it up in 2-3 minutes. The governance and implementation of policies need to be looked at. The Aadhaar ID creation, health facility registry, and health professional registry. These three need to be created, and that we call as M1, M2, and 3 integration of ABDM. The uptake of technological interventions and training and capacity building, scaling of the innovations. But how do we do that? That's something again we need to discuss in house. I think subsequently you will be having parallel discussions. Once the innovation has been identified, how to scale it up further? What kind of pilots need to be done, and what kind of the check mechanism and methodology should be there, which should be appropriate to test it, and subsequently decide on the replicability and scalability. The collaborative partnerships, including innovators, implementing agencies, academia, think tanks, and that's where the role of development partners, private sector, NGO also comes in, and how we can create a platform where everyone comes together and look at the collaborative. And that's why I think this is one of those initiatives where all of us are together thinking about this. Concurrent monitoring and evaluation. That's why we have recently recently did a evaluation of the teleconsultation as such, where we realized that there are challenges with the connectivity at various places. The challenges with the waiting time right now. So how to increase the number of hubs, how to reduce this waiting time. There are challenges that after the teleconsultation, the drugs availability. How to improve supply chain management, how to leverage technology to improve the supply chain management and to ensure that the drugs are available. Because there's no point in teleconsultation if the required requisite drugs are not available immediately at that time only. Or if there are some, the consulting physician or the specialist needs some tests to be done, those tests should be available at that place. So that's the kind of challenges which we need to link along with the whatever DHIs we are now thinking of as such, and collaborative research and development as such. So the harnessing full potential, basically, it needs concerted action, it needs collaborative approach and discussing, and also involving all stakeholders together. Thank you very much once again for inviting me, giving me this opportunity, and looking forward to the further deliberation subsequently. Thank you.
Thank you, Dr. Kotwal, for stressing the need to address key challenges by pooling together diverse expertise and resources and ensure that research efforts lead to novel solutions that have a far reaching impact. I'd now like to invite Sameer Kanwar and Niranjan Joshi back on stage to facilitate the official launch of the program brochure. Thank you. Thank you. We'll now break for tea and coffee, which is being served in the pre-event area right outside these doors. Please join us back in 15 minutes. Uh, Please join us back in 15 minutes for a panel discussion. Thank you once again to all the speakers. Welcome back, everyone. Please take your seats. Thank you. I will call you on stage. Please take your seats. We'll begin shortly. Thank you. Okay. Welcome back, everyone. I hope you're all feeling refreshed after that tea and coffee break. A quick reminder that we will be felicitating. Quick reminder that we will be felicitating our dignitaries by pledging plantations of approximately 50 trees at Sundarbans National Park, West Bengal, under the project Trees for Tigers by planttrees.com. The second part of this event begins with a panel discussion, Building Sustainable Partnerships, Digital Health Innovation, and Public Health Ecosystems for Impact. I now invite our moderator and panelists for the sessions to the stage. Our moderator for the event is Dr. Anuradha Jain, Advisor, Health System Strengthening, USAID. Dr. Shirshendu Mukherjee, Mission Director, BIRAC. Air Commodore Dr. Ranjan Kumar Chaudhary, Advisor, Healthcare Technology, NHSRC. Dr. Uman John, Senior Program Officer, Bill and Melinda Gates Foundation. Ms. Pradipta Kundu, Director, Health Mission, eGov Foundation. And finally, Mr. Prashant Warrior, co-founder and CEO, Cure AI. Over to you, Dr. Jain.
Let's start with a bit of humor. So I was supposed to be a panelist on this group. And Sameer told me this morning I'm supposed to be a moderator now. So I was like, I had to get away by speaking something in 5 minutes, and now I have to deal with all this. So then he came up and said, I encourage young people to be moderators. Then I'm happy. At least somebody is considering me to be young. Thanks, Amir. That's a compliment. Anyways, so on after that lighter note, I think um, as USA, I think nobody understands the value of an ecosystem more than us because we started our journey on digital far, earlier than a lot of us sitting over here in this room. So 2013, 14, 15, there were a lot of digital innovations that were happening in USAID per se in very, very small scale. And there was a time when we had done some innovations in the state of Rajasthan, Assam, and it was a struggle for us as USA to scale up those innovations because people did not believe those innovations, and especially the e-Sanjeevani of the today. We tried it out earliest in the Rajasthan state. The the kiosk We tried that. The hub and spoke model, both in the nursing education in the private sector as well as for service delivery, we tried it out, but there were no buyers for it. There was nobody who was ready to scale it up in the government system. So I think having a policy, having an ecosystem that can actually facilitate a lot of these innovations to move forward, and having a platform like this definitely helps innovation to scale up, bloom, and go beyond local to a global platform, which we are experiencing today in this country. And a lot of gratitude and thanks, in some sense, goes to COVID for that. Because COVID actually made us realize that technology actually is important and can make a difference. So, from skepticism to optimism, from local to global, and from a momentum of progress, here we are today. But one thing that we all have to probably understand when we start this session is that a lot of solutions should follow problem, and not solutions being created and then problems being found. So with that note, I think we can start this session with the esteemed set of panelists that are sitting with me. And I'm honored to host all of you today and introduce each one of you. With starting this panel, there is we have 5 minutes each for each of us to speak, and then we'll have a lot of question and answers, hopefully from our audience. So, and we should give that honor to our audience, because after you speak, they should have a right to ask those questions. So, requesting all of you to please stick to the time, and I hope somebody from the organizers will show us the signals. So my first question goes to the team, or to the panelists from eGov Foundation. You are an organization that has worked with multiple various ministries. You have created solutions that are very, very citizen centric, very user friendly. So, my question to you is that as part of your work, you've been supporting governments across sectors and countries. What has your experience been in adopting and implementing digital innovations with government? That's my first question for you. The second one in continuation is, do you think an ecosystem approach works? How do you scale digital innovation with government ownership and ensure transition and sustainability? Over to you. Thank you.
Thanks, Anuradha. Yeah, very big questions. So I'll just share our journey so far. Um, One of the things when we work with the government, we look at, I think one of the principles that we follow is not to scale what works, but to ask the question, what will work at scale? Because oftentimes we have seen that you can put a lot of resources into a pilot, and we talk, several esteemed speakers spoke about pilots. You can put a lot of effort, resources into a pilot, make that successful, but when it comes to scaling, that's where the struggle is, right? So we always look at what is it that will work at scale, and hence our approach is always to build something which is minimum, which is because when it's simple, that enables it to scale. And that's what we have learned from, UPI, from Aadhaar. So though that's sort of a lesson that it's quite ingrained in our DNA. Um, The other thing is that when we work with the governments, we again following the same principle, we do not start with, a small pilot. We encourage that the pilot is happy, even if it's like, an initial sort of test of the platform. It happens at a scale where the real problems can be found out quickly. The other thing that we have seen is that, or we also, when we partner with the government, is to not take a paper-based system. And, digital transformation is not just moving from paper to technology, right? digital transformation is very different. How do you solve a problem in a very different way? What is the best way to solve the problem? So our process starts off with understanding the problems and then coming up with very minimum solutions that will work at scale. The other thing that we do, and it's probably connected to your second question, is we have actually seen the ecosystem approach work very well. We have today over 200 partners that we work with, government, for profit, not for profit. We have all sorts of partners, and we actually believe that we cannot solve all the problem. So there has to be a way that the platform that we build allows people to innovate on top of it. And this is what we even do with the state governments that we work with, that when the state governments, we help them in the initial part of the journey, but after that, we encourage them to bring on other partners to, and we have seen over 50 applications being built on top of our platform. So, and for that, we put in a lot of effort. We put in over 60% of our energy goes in building and supporting the ecosystem, which means continuous trainings to whether it's a private sector entity or a government IT department. So, whatever it is, we spend a lot of time in making sure that they are able to innovate on top of our platforms. We also work very closely with the government to as a partner, to help them design from the very beginning that we engage. We help them design the pathway to sustainability. What kind of skills, what kind of teams, what resources uh, they are going to need, whether they have that in house, how are they going to source. We help them, we ideate that with them so that they are not only dependent on us to do the work. So we build in that right from the beginning when we engage with the government. So these are some of the things that we do. And like I said, we have a large ecosystem that today can work with the platform that we have, which is Digit, and they're still continuing to innovate and build new solutions and products. Um, but we also make sure that we are underwriting the platform cost and making sure that people are getting that support from us that they need. Um, so, yeah.
Thank you. Thank you. Thank you for those 4 P's from you that we got. It has to be plain, partnership dependent. It has to be a platform which is transparent and pathways to sustainability. Thank you for that. And with that, we move on to Dr. Ranjan, our next panelist. Sir, NHSRC, as we heard this morning from Executive Director NHSRC, is setting up an innovation platform. There is an existing platform where innovations can be, or best practices can be uploaded. And your team is one of the teams that's working on the criteria on SOPs of how digital innovations can be scaled and can be brought to that level of scale. You are in fact helping partners. We also bring a lot of partners for support to you. So, sir, in this journey, as you're working, what are the parameters that you feel or are important that you feel for assessing the technology for scalability? That is one question that I have for you. And when you assess them, how do you assess them actually for making an impact in public health? Because impact is very important in public health. And the second question to you is, sir, what have been some of the best practices across states that you've seen over a period of time, which have been well accepted by either other states beyond country? What are your experiences from?
Okay. Thank you, Dr. Anuradha. At the very outset, let me thank PATH, CCAMP, and my ED, NHS Sasi, to give this platform to share my views. It's really a privilege that my executive director is here amongst the audience. So, the government, as he mentioned it also, is always on a lookout and is very proactively looking to upscale and scale up the innovations. If I say in very simple words what we are looking, as you all know, innovation right from the ideation to scaling, it requires collaboration, it requires a lot of funding for the R&D, it requires support. So innovation in isolation cannot work. And if you want to know the mantra of a successful innovation, it is AAA. That is, it should be accessible, should be affordable, and it should be acceptable. Why I'm saying acceptable? Because the COVID pandemic has shown the pull model, there was an unmet need which came up glaring, and we immediately innovated, and it was accepted by all and sustaining. Rather than a push model wherein we keep on in bits and pieces innovating something and think that this will make a drastic change, we never take the user feedback, because there are many factors which my ED sir also said there were 36 barriers and challenges and all. So one must relatively use these terms when you find an innovation. Is it what is the novelty factor in it? What are the relative advantage? Uh, is it having a substantial health benefit when you place it in the public health system? Does it have a demonstrable and a distinctive evidence? Yes, this is going. Then only people will believe. That's the quality part of the innovation. So when we assess innovation, that is the second question you are asking. When it comes to us, we have an excellent platform. Is an IT platform, and I'm very happy that in this August audience, I'm able to showcase that, as my ED sir has said, we are going to soon. We have revamped that portal. Now that portal you can open, you can submit, and we have made system such a way that anybody from anywhere, any organization can submit their innovation and their ideations. There's one factor. We are not looking at these, TRL below 7. What we are looking is pre-commercialization and TRL 8, that is the commercialized. So that if at all we scale up, those technologies should be available. Unfortunately, in the country, even if you select a technology and you would like to scale it up, you find that it's not available. That guy has not got the wherewithal to scale it up in a high proportion. But it requires a ecosystem to support him, and there is a disconnect. I may find that this is very good, this should do well, but it's not available. So our platform as a national health innovation portal, now the revamped one, it can be easily accessible by everybody. You can all submit your innovations, be it personalized individual or an organization. They come to us, it gets shortlisted by a TAC. There's a ministry has constituted a technical advisory committee, or JS policy. Vishal Chauhan sir, he is the chairman. Each and every innovation is appraised. We appraise basic on few parameters. The scoring criterias have been revised, where we have brought in these three factors which I mentioned, novelty, substantial health benefit, demonstrable and distinctive advantage, safety. The CDA also, as you know, in the medical device sector and the device policy, they also encourage new innovations and all. Unfortunately, you in country, we have only around 49 of the medical devices under regulated. Now, once you get a license for manufacturing, and then after that, the post-market surveillance and the safety calls are very poorly defined. It's not at all such robust that we can get post-market a new device has come up, and what is its data sets on patient outcome, not available. So that becomes a very big challenge for adoption. uh, However, there are instances, I'll give you examples. Uh, like simple, I'll give you the Anemia Mukt Bharat uses one equipment. It's called as hemoglobinometer. Now, Department of Health Research, they had done a
HTA, and they found that true HB, because HTA is done between choices. If you have two choices, which is good. So they've just listed out the true HB system. It is 3 times better in its sensitivity, specificity, NPV, PPV than HemoQ. But it is available. Now the states are to use it or buy it, but they can't. Why? Because they go in a tendering system of L1. There they find all other system which are Chinese made and all. Then your HTA, you're telling that this equipment is good, will give a reliable hemoglobin valuation. It doesn't fit in. So a mechanism how we can make these selected technologies for uptake and its adoption to make it sustainable. This is only on product. There are models. I'll tell you, like I was discussing with my EDs, the teleophthalmology, fantastic model, telepathology. Now, in patches, it will work where the leadership is very, very important. He mentioned about the leadership part also. Now, the moment it is working and the leadership is vacuum is there, it stops. So there's a big question on its sustainability. So it should be put into place today. India has got a system, like she just mentioned, my previous speaker, that the ecosystem they try to develop, it has to be very simple and usable. The teleradiology is comparatively much better and has been accepted well. Why? There is a shortage of radiologists and there is a shortage of radiographers who can interpret correctly. So using AI interface with teleradiology, you can get excellent results. Similarly, if you get a slide digitizer, imagine the telepathology. If you start, if you've got a shortage of pathologists and all sitting in the district headquarters, they can comment and they can have a lot of breakthrough. I'll say step changes and breakthrough changes in that. So this is what is required for any innovation to scale up. Yes, there are various models in the world. Like if you give some GST exemption, make it a price lower, automatically it will come. Or you reward that innovator with giving a good, saying that your item will be priced at this and rest all, you will have a premium on every product sold by you. Certain side of government policies have to be adopted to boost, and we are working on that. The Ministry of Health and Family Wear is quite sanguine of this. That is why this single vertical have been created, so that the visibility is available to everybody. So with this visibility, and we want to connect with everybody, that all innovation should be apprised and we should know which is good and which can be taken up for our public health system uh, very quickly and upscaling. So I'll request all these in the August audience also, whenever the innovations are put up, a small brief should be made about its how it will be scaled up. There is a factor in a scoring also, scalability, which is not understood very well by many people. But that scalability we must mention, how you are going to take it up or scale it up and sustain that. So I think I'll pause here. Thank you.
Thank you so much, sir. Beyond your three A's, we gathered another three A's from you. And these are the relative advantages, the accessible, adaptability, and definitely, as you said, at one point of time in our side conversation, the procurement policies need to be relooked into of how these innovations are adapted in the government system. Thank you so much, sir, for that discussion. And our next speaker is Kapil Vijay from BIREC. Sir, BIREC pioneer in innovations. You have had various partnerships with industry, with academia, and you have worked with global partners collaboratively to bridge existing gaps in innovation research, facilitate novel, high quality, affordable product development through cutting edge technologies. So, my question to you is, with your immense experience of working in this domain, can you share some learnings from partnership that BIREC has built over the years? And the second question for you is the confluence of industry and academia, and the startup ecosystem. How important is collaboration to achieve balance between scale and sustenance?
Mm. Thank you very much, Dr. Anuradha. Firstly, I thank Neeraj and Tasleem for the invite. It is always very difficult, as Sir said, to say no to them, and you have to reject the calendar when they call me and send a mail to come here. So thank you, Neeraj and Tasleem, for the invite, and congratulations for the partnership and the initiative. As Ma'am said, I come from BIRAC, which is an acronym for Biotechnology Industry Research Assistance Council. It is a public sector undertaking supported by the Department of Biotechnology, Government of India. And our main purpose is to enable the innovation ecosystem in this country. We work with three I's in mind, which is ignite, innovate, and incubate. That is one of our main mandates to work upon. Though we are a funding agency, 60% of our time goes in funding programs and projects, but 40% of our time is to enable the innovations which we fund. As you rightly said in the beginning, we should, literally look at the problems and that look for innovations. Sometimes it goes reverse also, but we try to bring them to the track. And BIRAC's job is literally to look from the bottom of the pyramid to take it to a level where it can have a exit strategy defined into the program so that it can really impact our country in the right unmet needs space. We work across portfolio. We work in health, we work in nutrition, we work in agriculture, we work in digital health, we work in medical technologies, drug discoveries, vaccines. And the very important thing is that the COVID, which passed off, I was a part of the mission COVID Suraksha also, which developed 5 vaccines. Not only the vaccines, but we look at vaccines as our end product, but the background work which went into development of these vaccines. That is, we literally enabled 50 clinical trial sites, 5 bioassay labs, 2 animal challenge facilities. That really helped the innovation ecosystem, and our country has all the global 5 vaccine platforms which is needed to address any other pandemics. Touch wood, it should not come. We should do that. And thanks, because that was a great initiative by the government which started, and that literally enabled the ecosystem in this country. Because if you see, Pfizer produced around 3.5 billion doses of vaccine. Moderna produced around 1.5 billion doses of. Our country needed 2.5 billion doses to get 2 doses to everybody. If we didn't have this innovation ecosystem, or our companies, our startups, our academics didn't come to this rose to this occasion, we would have not been able to vaccinate our country. I think that was a great initiative by the government, far-sightedness by the government, which literally put in 900 crores at the very beginning that we should not go out to take vaccine from any MNCs and things like that. Firstly, the cost, and then getting the number of doses for our country would have been very difficult. So that, Mission COVID Suraksha played that role, and I'm very fortunate to lead that. Department of Biotechnology led it, and it was implemented by BIRAC. Coming to the innovation part, and if you see the beginning of COVID, we literally supported the entire innovation ecosystem. Tasleem is sitting here, from diagnostics to PPE kits to ventilators, through various of our innovation platforms. We supported that. We funded them almost overnight basis to see that we get the right innovation to our ecosystem built in. How we do that? We have a concept called farming of innovations. Through our 75 incubation centers across the country, we farm good, and Tasleem leads one of our flagship incubators, C Camp in Bangalore. We have 75 incubators in our country. There are 7 prime incubators, and there are BioNest concepts which we have created in academic settings. Because academic, you had that question in mind, that how academic industry startup should work in partner. That is very, very critical element. Firstly, the confidence between the academic and the startup and the industry, then the funding element, and then working on the exit part of the innovation. Because innovation, as Sir said, unless and until it has an impact. I always do a lot of grant writing workshop for my startups, and I always say winning a grant is telling a convincing story to the funder. It is just like a fairy tale which starts with once upon a time and ends with happily ever after. I think so. I think the story has to be such that the impact of the innovation has to be very well assessed, and that is what it can only happen, as you said in the beginning, if you look at the problems first, then design the understand the unmet area, and that is how we look at to see the innovations going to the left. We have funding pots for all level of innovation, starting from pre-proof of concept funding to proof of concept funding to crossing the valley of death, that is the translational funding. We last 2 years we have announced a product commercialization grant also, so that if the product needs to enter the market, we give funds for them also to see that the product reaches the market. And this is not only achieved by funding, but a critical hand holding into the entire, we call it 360-degree hand holding to the entire innovation cycle, to our startups, to the academic community, and to the industry as well. We literally support from how to write grant applications. That is the storytelling part of it. And then building them to cross the IP pathway if there is any, the regulatory pathway if there is any, and then building a business plan to get into the commercial exit or the commercial marketplace. We have started a concept call, and thanks to these, the idea came from Professor Vinod Paul at Niti Aayog too, and then Secretary DBT Dr. Swaroop, is that we have a concept called Open Darbar or Khula Darbar in Bairak, which is held in first Friday of the every month from 3 p.m. to 5:30 p.m. And my colleague Dr. Sharma leads on to it. Is that any innovator can come walk in into our offices either online or physically, and we have all key stakeholders sitting into the room. Like as a funder, we are sitting the Department of Biotechnology, Indian Council of Medical Research to do the validation, then representative from CDSCO, representative from that biological institute in Noida. Then we have GEM person, because the major concern is, as was emphasized, if the innovation comes out, how it gets into the procurement system. So a GEM representative is there. We have a representative from AMTZ who helps us to do these scale ups. And so I think there the innovators are literally brought inside the room, and we try to solve their problem and get them connected to the right space. So this is how we literally build and handhold innovation to see the the success rate of funding is around 8 to 10%. We have flagship grants also, which gets 1,000 applications, but out of them 40 or 70 gets funded. Out of this, only a 5 to 7 for 10% maximum has literally going to the next level. So you literally have to, as I said in the beginning, we have to farm lots and lots of innovations, plug the right innovations to take them to the next level. You talked about global collaborations, and through Department of Biotechnology, we have two major global collaborations in place. And these collaborations are not for funding, but learning from international expertise, which is very important. One of the oldest collaborations we have is with the Bill and Melinda Gates Foundation, the Grand Challenges program, which is literally looks at our country specific challenges which we face, starting from looking at maternal and child health solutions, immunizations, the last mile delivery of vaccine, how it can be digitized to see the vaccine reaches the last mile, antimicrobial resistance. We have programs on data sciences, artificial intelligence, so and vaccines. So the foundation brings us with us the global expertise, the learnings globally, and how we can learn with each other to be implemented in India. So we have almost 24 programs together under this ambit of Grand Challenges India, which looks at how we can find out. And again, this is open for our young innovators, our academics to work together, and the challenges which our country faces, and then converting those challenges into research questions, and then drawing out of an RFP for those research questions and throwing those challenges to our startups and the academic communities to come out with the solutions. The second important we have with the World Bank called the National Biopharma Mission. It has 5 verticals on medical technologies, vaccines, diagnostics, therapeutics, and technology management and transfer. So here also it is a joint initiative with Department of Biotechnology and the World Bank, where again we are looking and exciting the innovator communities come out with challenges to solutions for the problems which we are facing. And this is how we literally trying to build the innovation ecosystem in this country to take the innovation not from the academic shells. Of course, publication is needed. They need to publish it, but how academic innovations can literally go out and literally help us to have solutions for us in India, but not only in India, but it can cross borders as we did in our COVID. We literally crossed border. We supported a lot of people, a lot of countries under the vaccine Maitri program. So I think that's what is we call the programs are in India, for India, and beyond. So that is how we will literally target innovations to take them to it. So thank you.
Thank you so much, sir, for stressing on the need of funding for such flowers to bloom. And right from an ecosystem to the education part of it, and then the exit strategy. I think this is a 360-degree approach, and grateful for organizations like BIREC to take them forward. And the question of funding brings me to our next esteemed speaker, Dr. John, and from Bill and Melinda Gates Foundation. Sir, with its data for health platform that you have and initiatives and multi-agency collaborations, the foundation has been driving sustainable development and meaningful impact in critical public health areas in the country and beyond. So my question for you is, funding priorities for public health have evolved over a period of time. And Bill and Melinda Gates Foundation, as one of the largest funders, uh, has seen substantial changes happening post COVID. So how do you look at these changes, and how do you look at your way of funding beyond uh, beyond the COVID times? The other question for you is, since we have a lot of innovators sitting in the room and you are a funding agency, what is your suggestion for them while you are making a decision on your investment? What would you like to see from these innovators coming your way, which would excite or incite you to fund them?
Thank you so much, Dr. Thank you, Neeraj and Samir and CCMP for having me here. It's an honor and a privilege. So, if you were to look at COVID, what has COVID taught us? It has taught us that if we really have to come out of it, you need to have strong primary healthcare systems. You need to have health systems with people who are able to be quickly trained on new protocols, on new ways of doing work. And it also taught us that we need to have a very, very coordinated care delivery mechanism. And has COVID gone away? Perhaps yes, but has the kind of effects of what COVID has left behind in terms of bringing to the surface the dysfunctional uh, health delivery systems, not only in our country, in several parts of the world, particularly in middle income country settings. Why is this? Because it is a design problem. Our health delivery systems were designed for a time when disease portfolio was very different. Today, you have one people who are very impatient. We call them patients. We expect them to be patient, but they are not, because in 30 seconds they are able to get things delivered in 30 minutes in their homes. They expect the same kind of efficiency for their health services delivery as well. Do we have systems that deliver? Perhaps not. Do we have technologies and platforms that can help us deliver? Yes. And I think one of the things that we realize, the foundation as well as all the ecosystem partners realize, is how technology can be a huge enabler in care coordination, triaging as a primary care point of contact, and also making sure that information asymmetries that currently exist can be overcome. So, one of the fundamental problems that we saw during COVID, especially if you contracted COVID and you needed hospitalization, is not knowing where to go. Nobody knew where they could find a bed. So what did many people came together from civil society, from innovators, from a startup ecosystem, came together, built platforms to make sure that this essential information of where to go when you are falling sick, or where to buy medicines, or to where you can get oxygen and things like that. So while we don't have that effect of COVID, perhaps many people living in rural parts of India still struggle with same questions. If they fall ill, they do not know where to go. So can we bridge this information asymmetry is something that we are working on, and we are working with our ecosystem partners to make sure that this can be done. And I think we have a lot of promising technologies that are coming with the ABDM, the ABID, and the registries. So you the whole idea is that you should have discoverability of services, service providers, as well as provide other providers, including diagnostics. So one of the fundamental things that we are currently focusing on and working on, can we ensure a digitally coordinated care coordination mechanism, provide either tele or in-person assisted triage for primary care, ensure a ticketed appointment is given, and that there is some amount of observability that is brought into the system, which is exactly replicating what many people came together and did during COVID times. Can we really build that for non-COVID season as well? Perhaps because people in rural parts of India are facing a COVID on a day-to-day basis, and these technologies could help us. So one question to the innovators here is, can you look at health systems as a microservices architecture and build components into that microservices so that you within that enterprise architecture you talk to each other and you're able to support each other rather than build individual applications of excellence which stand in silos and like Secretary Sir said this morning, saying we collect a lot of data and we don't really use the data meaningfully. So here again, one question that we have is, can we generate data as a byproduct of service delivery and not necessarily having our frontline healthcare workers to keep inputting data? And most other domains have done that. Financial services, nobody asks you, please enter your this detail on this product you're pricing. When you're actually making sure that you're taking a service, all of that data is generated out. Today, perhaps our financial service providers know more about, have insights about our health than our health systems do. Why? Because meaningfully, they are able to collate all the information that we are giving in the process of rendering or getting services, and they are meaningfully using it for worsening our health outcomes by providing us more options to have unhealthy behaviors. So again, I just want to turn our eyes to some of the earlier innovations. Do we consider X-ray as an innovation? It was a path-breaking innovation. It still is. Do we consider ORS, oral rehydration solution? What were the lessons from that? It's simple. It's easily replicable anywhere across the world, and even an untrained mother can use it. Has it reached scale? Yes. Has it saved life? Yes. So can we move to building ORS like digital solutions that can be used in any remote part of India or any low and middle income country, that can be easily rendered? So if your innovation is coming with a user manual, you've lost it. Okay. It should come with ease of use, that no user manual, no help function is needed. Please keep that as the first and foremost objective. User centricity in design and involving communities that are going to be using in design. And these are some of the things that we are focusing at the foundation. Thank you so much for the opportunity.
Lovely. Those were wonderful points. I think usage has to be inherent when you design anything. And if it needs a guidebook, it means it's a failure. Thank you for that message. It's a very strong message going out. And that brings me to Prashant, our next speaker from Pure AI. And you have been one of the market innovators that have come up with a lot of AI solutions and which have worked really well in the market. You have partnered with government, you've partnered with public, your innovations have scaled. Was it a designed way of scaling that you achieved this success, or it was just a coincidence that it happened?
That's a great question. I would actually like to say by design, but probably not. I mean, in a lot of startups, things happen by coincidence. You sort of get into the right markets. I mean, uh, when we started Cure, I mean, first of all, thanks to Path and thanks to CCAM for having me here. Like everyone said, it's hard to say no to Neeraj. So Um, yeah, so when we started, we said we want to build AI for radiology, and we spoke to radiologists in multiple parts of the world. We spoke to people from radiologists from Columbia, Asia, uh, somebody from Medanta, somebody from Harvard, and almost everybody told us that you should basically build AI that can interpret chest X-rays, because there is about a billion plus, I mean, about a couple of billion chest X-rays taken every year around the world. and most of them are not interpreted or interpreted after 30, 40 days. In fact, even in NHS, uh, which is one of the best health systems in the world, it takes 60, 70 days to get an X-ray read. I mean, there is always a backlog of X-rays, right? So it's always challenging. And with new modalities, like you said, Dr. Ruman, that X-rays were a technology which is obviously a very innovative technology, right? But now the interest is in interpreting CTs, MRs, ultrasounds, PET scans. So X-rays have fallen back, but the reality is there is still so many of them taken. So we said, can we interpret X-rays? And we built a complete X-ray interpretation software which can interpret all kinds of findings from X-rays, from detecting a cardiomegaly, which is an enlarged heart, to finding a pleural effusion or nodules and everything else, right? And so, interestingly, I mean, we had, and so Sandeep is in the audience. Sandeep is part of Fractal. He leads one of the practices at Fractal. And Sandeep and I had a meeting with, and Fractal incubated Cure. So Sandeep and I had a meeting with the health secretary, Mr. C.K. Mishra, back then. And we were thinking about what kind of problems might be interesting for Mr. C.K. Mishra to look at, right? And we obviously presented, we had multiple solutions. Chest X-ray is one of them. And we obviously presented that. But I mean, at that time we did not realize that TB was such a big problem. I did not realize that. Even today, I meet people who say that TB is solved. I mean, do we really have TB in India? And people don't know that there are more than 2.5 million, 25 lakh people who have TB in India every year. There is more than 1.1 crore people across the world who have TB, right? And all of us feel, I mean, we are in a world where we feel like it's solved completely. I mean, TB is gone because we don't encounter people who have TB, but it's a real problem. And so when we had that meeting, we realized that there is an opportunity to basically address TB as a problem. So we started thinking about that after that meeting with the health secretary. And then we sort of fortunately also went to the union conference, and there we again met a bunch of people. This was in Guadalajara back in 2017. And we met a bunch of people who said this is a very interesting problem to solve. So we basically took our X-ray solution and then converted. Obviously, it could detect a lot of findings which are indicative of TB. It could detect nodules, it could detect cavities. And when we trained a model which could detect TB on a chest X-ray. And that is how we started on this public health journey, because we started addressing TB as a problem. And we were very fortunate that Path, I mean, back in 2018, 5 years back, they actually sponsored a research project which in central India, in Nagpur and surrounding areas, to evaluate our technology, to evaluate the efficacy of our technology, to measure the accuracy of our technology. And that was the first project, I mean, where we deployed TB on ground. And then, of course, I mean, from that, we've seen many studies, and that was presented to Stop TB. That was a Stop TB funded program, and then we've seen a massive scale up. So I think we sort of, I mean, we came into this path, and we sort of found our way into the TB community, and we found that we could address that using our solutions. And then as we started doing that, we realized that there is more opportunity to work with government. We have stroke solutions, we have lung cancer solution, we have I mean, chest CT AI, we have got head CT AI. So started doing more work with government, but still a lot of our public sector work is around tuberculosis. So that's our journey coming to the public sector. And typically, one thing which I wanted to say is that for startups, it's very hard to work with government because the time to win a contract, time to commercial is very slow, right? And whenever you're a startup, you are funded by investors, and they want quick returns. They want to see revenue growth of 2x, 3x every year. And so it becomes hard to get to that number if you are funded, if you are looking at government contracts. So again, we were fortunate to have a mix of public and private where we could do both at the same time.
Thanks, Prashant. So, you stressed on the point, it was not coincidental, it was a designed pathway. And thank you for that. I think a lot of people can come and learn from you about the designed pathways. I think we have a little time, but we would like to open for at least 2 or 3 questions from this August audience, because a lot of brain strength is sitting around in the room. So, anybody, please, the floor is open for questions. Please introduce yourself.
Yeah, thank you. I'm Bob Jan from Bhopal. Thank you for this meeting. It has been fantastic. Since morning, hearing most of you here. I don't know whether I call it a question or comment. I have three parts to it. The first thing that I heard, and I really bring for hearing it, digital health innovations, there's a freedom of information. And somebody said there is also a area. And when you look at that, I think that many of the digital health platforms or solutions have been issue-centered or disease-specific. They have not been diagnosed. Probably in terms of taking up what John mentioned in terms of microprocessor investigations. Is there any towards broad scope of the digital development beyond the disease or issue? The second thing is we have heard lots of digital health solutions that are being implemented beyond the last week. But how do you think that in India, let's say, is where the common question is we learn? How do you think that sort of information are involved in that? The third thing that I'll take relates to this particular when happening, we have talked about this normal things. We know that we don't have then there sort of move towards it. One to be generation. The third capacity that happens on the one together and is there sort of move towards this capacity of digital health innovations and innovations? And do we have a stockpile of their countries that are part of the stockpile in this? With this forum, I was also ask both Park and CCAN in terms of having a sort of an innovations marketplace because there's so much that is done with the graveyards and epidemics around. There's so much done. Can somebody walk into your solution or your innovation center and pick up stuff and say that, okay, I want this from this, I want that from this, I want this from this, so that I can suit it up for my own sort of customized sort of solution? Is there a move towards doing that? So, thank you.
Thank you. Jamie, these were suggestions, or are you expecting answers to these? Dr. Chaudhary, and do you like?
I'll answer the last question, the innovation marketplace. In fact, the World Bank funded NBM with DBT has one vertical on technology transfer offices. So this is sort of we are trying to build up a innovation because these TTOs and one is at SICAMP also is sort of scouting for innovations along their territories and geographies, bringing out a portfolio of innovations, which including digital health innovations, and then asking the relevant stakeholders, may it be a company or a organization which can scale it up, to take these innovations and do scale it up and design a strategy for it. So that thinking is going on, and we have 7 TTOs across the country through this initiative looking for creating this innovation marketplace to link into the innovation ecosystem. So I will rest that.
Okay, one very important point what we must remember, digital health innovations comes with digital literacy also. So in the country right now, barring one or two states who have declared that we are 100% digital literate, I can say Andhra, Kerala, still much is required for people to be educated, right? Using mobile is a different thing, but using an app to its full potential is another thing. Secondly, the connectivity issues. Well, we have not permeated to that stage, though our 5G system may be the best in the world compared to the data rates are so cheap. So the future is good, not gloomy. So graveyard shift is going to happen to a better productive stage. Our idea is to have good solutions. Now I'll give you example. You all be knowing that in a hospital people would like to go 10 to 4. So that's the queue management system, the queue forms, however early you go, the doctors, everything, system starts at queue 10 to 2. Servers are less. Why can't we think of automated slot systems? We have tried out in some places, but for that you require digital literacy, you require people to opt for it. I'll give you now practical example. I visited Jharkhand and all, and there the Ashas are called as Saiya, I think, right? They have a Sia app. So I interacted with the Ashas. I said कि how good आपका app है. Sir बहुत अच्छा है ये. मतलब कैसे? उन्होंने दिखाया कि सर इसमें हम सबका पता चल जाता है कौन कहाँ पे है, क्या है, अटेंडेंस हो जाती है, हमारे कुछ भी कम्युनिकेशन. So in innovations, this is very important. Another part is communication channels and training of that guy, awareness, ease of use, what he mentioned. These all have to be inbuilt. Isolation, you cannot have a good innovation. So innovation in processes, in methods are much better. Digital health apps and all, they keep on coming. We keep on seeing it. But any app in isolation will not work. It has to work and fit into the system as easily as, and it should bring in a value addition. So a referral mechanism, a continuum mechanism. I was very happy when I, turned it on this side. They are thinking about using a POC diagnostics with teleconsultation, teleradiology. So these all thing will be integrated to give a better result. At the same time, we must canvas to make sure our digital infrastructures are in place and robust, so that people should not lose out. That reliability factor is important. I'll tell you, I we developed Pradhan Mantri National Dialysis program in a very nice integrated one nation one dialysis IT portal, and we realized ki without internet in Manipur and all, they are not able to log in data and all. So what will be their reliability? So quickly we have developed an offline module of the mobile app, and we have now circulated to everybody. In case there is no internet, please keep on doing it. You can sync the data, and that was done by CHI in record time in 2 months, and we have given to all states. So focus should be on the having the clientele's reliability on the digital system. You can make any innovation, anything, but if you don't have a reliable system to carry it on, it will die its own death. So that's what I think. Otherwise, things are good. The government is trying its best. I say that procurement is an issue, but there you all know that there is an IP act and all. You can buy items which are proprietary, saying PAC, proprietary article set. In GEM also you can buy. But unfortunately, people are hesitant to use it. Might be unaware or something. I have used many times to buy a proprietary article. So the proprietary article, if at all, we have put it in our government this thing also to scale up. This is one way, but availability of that item is to be ensured. That's what I was trying to hint that time. In the GEM platform, wherever when you have bulk orders and all, I'll give latest example for sickle cell anemias and this. We did an HTA and we found Gazelle is a very good POC device at a PHC setup. It can do almost 16 investigations and very cheap. So we are trying to fit it into that. So this technology solution, which can be easily done, you can just have a small, blood sample, and it will give you a, very good outcome. That's what we are looking. Thank you.
I was talking about the whole digital health learnings of building a digital health solution from Cure perspective, right? Because a lot of them fail, and at least my experience building this out has been that, especially in public health, you have to think beyond point solutions. We are a point solution. We provide interpretation for X-rays, CTs, MRIs. I mean, some MRIs, some ultrasounds, right? So we build that capability, and um, when we started providing this to customers, we realized that the ecosystem is not there, like you said, sir. That you have to go beyond just providing that point solution, and many times small challenges, right? I mean, for example, when we started, we realized that, I mean, typically we integrate with PACS systems. So typically a lot of more mature hospital systems have a PACS and EMR system, and we provide our AI. It will integrate with the PACS and EMR, get a scan, process it, send the results back. And that is what we built out. But we realized that a lot of hospitals in India, Southeast Asia, Africa don't have access, don't have a PACS system. So we actually had to build a PACS system. Now you cannot buy buying a computer is expensive. So to make it for the mobile phone, so we built a PACS system which is available on the mobile phone. So a scan gets taken, and then you can see the AI results on your mobile phone. You can see whether it's TB or whatever findings we found, right? So again, it required us to go beyond our point solution, build more of the ecosystem. And ecosystem, there are even simpler problems, right? For example, on-ground support is required in a lot of places. What we realized, for example, is that in Mumbai, we had this intervention where one of the sites, they were not using a technology, and and they were not basically. So in Mumbai, what we do is every X-ray that gets taken is automatically processed for TB. If we say if it's positive for TB, immediately that patient goes and gets a gene expert test. So we send them directly to the gene expert test, making sure that there is no loss to follow-up cases, right? And so that was the case, and we saw that one hospital was not doing it. We realized that they did not have a pencil to note down that which patients are positive because they did not have that pencil and they had to procure that through a tender or whatever. They were not doing that. So as simple as just giving them a pencil solved a problem where you are diagnosing patients much faster. And in Mumbai, we are finding that we found about 35% cases were incidental diagnosis. So they were not in the TB pathway. They were diagnosed purely because AI was looking at every scan and making sure that you are looking for TB on every scan that is taken, every X-ray that is taken. So again, it's sort of one of the things we realized is as compared to NHS where we work with, we deploy a lot, work a lot with the NHS. Uh, we have to have on-ground support here because there is not enough support for the hospital staff. So again, thinking about that kind of intervention, right? Going beyond technology and thinking about how do you solve a problem for the end user is how you get there.
Thank you. One last quick.
Yeah, I think so. I've been here in digital health for 14 years, and I can relate to the silo problem. But what gives me great hope is the Ayushman Bharat digital mission, because I think for the first time we have taken a very different approach. We are building digital public infrastructure, and what that means is we are not building solutions. The government's not building solutions, but building roads, right? And when you build roads, all types of vehicles can, move from place A to place B. And what also, if you go and see their website, they giving technology or solution providers how to talk to each other. That means that imagine if all of us spoke our own different language, right? We would never be able to communicate each other. Today, that's what is happening in the technology space. Every system has its own language. So this Digital Bharat mission is actually creating a language in which different technology solutions can speak to each other, right? A common language. And that, I think, is a game changer. And I think government is also promoting and helping with the adoption, because I feel like that is the way forward, right? You will never have one solution that fits all, and you should not try to build one solution that fits all. Like what Prashant is doing is brilliant on the diagnostic space. Somebody else will be solving a problem in the curative space. But how do you put all those things together to solve the larger use case that they were talking about in the morning? And we already have that sort of, the infrastructure is coming up in the country to support that.
Thank you. And I must thank such a brilliant panel for wonderful insights. I think we have all learned a lot from you. And I would like to end on a note saying technologies change. Let's make agile systems also that can change and adopt technologies. As the EDNHSRC said this morning, it's not the most robust and successful one that survives. It's the one who's ready to change that survives. Thank you. Thank you, everybody.
Thank you, Dr. Jain, and thank you to all our esteemed panelists for this important discussion. We will take a quick pause before the final session of the day, the fireside chat. Thank you. Hello. I would now like to invite Mr. Ratish Balakrishnan, co-founder and managing partner, Sattva Consulting, to facilitate a very special fireside chat between Neeraj Jain, Country Director, Path India, and Dr. Taslim Arif Saeed, CEO and Director of CCAMP. Please join me in welcoming Ratish, Neeraj, and Dr. Saeed to the stage.
Just wondering where you were.
Yeah. It's great to actually follow up this enriching panel that just happened, and also being fully aware that the three of us are between them and lunch. So, so we have to be as engaging and as interesting as possible. The pressure is all on you; it's not on me. Uh, Thank you so much for joining me on stage. It's my pleasure to talk to the two leaders who are actually orchestrated this collaboration that everyone here is excited about. And I wanted to take a few minutes to ask you a few questions on really why this collaboration, what this collaboration, and how will success look like for both of you. And it is my pleasure to talk to both Taslim and Neeraj on this question today. I think the audience and the speakers before have made it clear it is probably the right time for a partnership like this to happen. There are so many enabling factors. But Neeraj, I'll probably first come to you. What sparked off this idea of a collaboration and what are the motivations behind it?
Thanks, Ratish. We'll do this Karan Johar style, okay? Rapid fire. We'll do rapid fire, all
So
right?
you say Karan Johar, it starts
Yeah,
beeping.
you see
So
what happened? No, but thank you so much for that. Yeah, I think when we looked around, we see so much happening.
Yeah.
But it's so fragmented. It's just all over the place.
Yeah.
We find that there is a trust issue between private sector, government. What's happening in the public health space. There needs to be some sort of a, I don't know what to call it anymore. When I said ecosystem, somebody said, everything is an ecosystem. Yeah, I remember. Rajiv, that was you, right? Everybody's saying ecosystem, all these words, right? That we keep using. But I think the idea is just that with the power of incubation and that CCAM brings, and with some of our work that we do on the ground, if we are able to bring this together, and if we are able to really look at what are those game changing ideas and how are we going to ground them from a pure thought process of impact. So start at impact and come backwards. We'll probably get something going. I'll stop.
excellent. Neeraj, thank you so much. And for me, what was exciting also was as I was reading this brochure, the actual identification of use cases and problems we're going to solve. Starting with a tangible goal that we want to reduce neonatal mortality, work backwards. I think that is super exciting. And Taslim, over to you. I think a collaboration is always as good as the two organizations. And it has to be when 1 + 1 is equal to 3. Because if it's equal to 2, then what is the point? How would you see the strengths of the two organizations, and how do you see that 1 + 1 equal to 3 happen here?
Yeah, no, thanks, Tish. I I could be a defaulter in being as prompt as them, but I just want to take your permission for a little bit of context, if I may. I think as CCAMP is now almost now 15 years, 14 to 15 years old, and as we have been traditionally building deep science innovations, over time, since our products are coming out, since some really stunning work that is coming out with support of many agencies in Delhi, BIRAC, DST and AIM and many more. During the COVID times, we realized that the impact was the most gratifying thing once you actually innovations hit the market and we can possibly touch lives, save lives, and so on. And as possibly the words were used here, I think the importance of deploying them and deploying them rightly and building a case for them to actually be systemically integrated is a very important cause that we found that it was right time. And what better partner than Path and Neeraj to actually look at it and say, how do we do this phenomenal contextual innovations, which many of us, not only CK, many of us have built together. Now they are waiting for them to be, making impactful, but systemic small gaps are not allowing them to do that. So a structured approach coming together with CCAM and Path, not only that, but many others, hopefully, as we go forward, how it actually make it realize the potential that we are talking about for years. How to do it in a structured manner, solve few problems in priority, and then scale it up beyond that is the part. And I think I had no doubt in my mind when Neeraj conceptualized it right in the beginning and actually said, why don't we do it together? I said this was a brilliant idea. We have been waiting to build those now scalabilities as a next step of our evolving nature of our organization as a change that is required. And it was a perfect partnership. So we are as excited we are about partnership, we are actually possibly more excited about what this partnership will come together and bring together 1 + 1 3 or 1 + 1 11 or 22. So we are
Yeah.
hoping for the bigger impact.
Absolutely. And I just want to add 2 points. And I've had a chance to work across sectors. And actually, what they say about value of death is not a financial problem. It is actually the systemic problem, which is what starts off at a lab, oftentimes doesn't get all the way to the field because striking friction issues solve for it. And when I see objectively the two organizations, and I've known both of your work for a while now, the combination is actually great because you have a deep understanding of the innovation pipeline, you have a deep understanding of the systems they finally have to be deployed to. And it's actually exciting that both of you are looking at it because this full view is often missed in any innovation pipeline. And from electrical vehicles to health tech to batteries, it's the same story, right? But I also want to ask you, Neeraj, that things like this have been tried. We've had conversations like this in the past across sectors and so on. And there is probably some of them who are sitting in the audience saying there is a deja vu about this conversation because they've heard it before. So what is different?
That's a tough question, actually, because I think the one big difference that is sort of very, very glaring is the two organizations, is what CCAM brings to the table, what Path brings to the table, and I think the combination of both. And Ratish, I must be very upfront with you and the audience. I'm not sure if it's going to work. Okay, are you sure, Taslim?
I'm hopeful.
But I know that he has a great campus and he has a great canteen. So, we'll get some of that food. But I don't think any of us are sure it's going to work. We're going in with all the best intentions. We are taking along all the important stakeholders in the ecosystem. We are going in thinking we have to course correct. We have to fail fast. We have to figure out what's working, what's not working. We have to be transparent and truthful to ourselves.
Absolutely.
The problem I find, and I see, us also doing it at times, is we keep convincing ourselves that we're doing really well. But actually, if you really, go to the bone, a lot of the stuff we do is actually not having any impact. So we'll have to be transparent. We'll have to be upfront. We'll have to say this is not working. Drop it, move forward, change course. And that's the only way we'll be successful. And I think we need to have this chat again in about a year.
Absolutely.
And either that's going to be because we are closing the program down because it's not working, or it's going to be cheering for success and moving forward. But we're going to go in with the best intentions, and I'm pretty sure it's going to work.
Yeah, and I want to build on what you're saying. I think knowing the fact of what is the probability of success is the starting point of being successful. Overestimating it oftentimes is the reason why it fails. And secondly, I think the point you said, as long as we are able to build good feedback loops, how quickly are we going to learn? I think is going to make a big difference. And how quickly are we able to share? Because as the moderator Anuradha said it beautifully, the intellectual power in this room is fantastic. So every once in a while to have a place like this to say, hey, this is what we are learning, what should we do differently, I think might be very, very valuable as well. And on that, Taslim, I want to come to you. You've seen a lot of innovations go through this cycle. Some of them have succeeded. Dr. Uman John rightly mentioned, a couple of innovations that have succeeded. What are some of the things that you're seeing successful organizations do well, innovations do well? And what are some of the reasons behind the misses that may not be their fault, but are some of the ecosystem gaps as well?
I think from whatever we have seen, I would say one of the biggest factor has been persistence. The understanding, listening in, and being persistent at it. some of the organizations who have done well have been constantly on the ground and not necessarily in their own few meter by few meter ratio. They have been constantly on the ground, listening in, coming back, building it again, on the ground, listening and building the business case, constantly on the ground, coming back, building partnership, constantly on the ground. The people who have actually have the ability to go on the ground, wet their hands, I won't say dirty their hand, wet their hands and build it, have been one of the ones and being persistent at it. The ones possibly an important thing is that in very difficult scenario, I let me be honest, and I think people have said it, it is not easy to get your product in the public health system.
Absolutely.
One can't even say it as many times, but it is very difficult. In this system to come out and be successful is actually you have done a humongous, effort to actually get there. Now with this platforms like this, those innovations who have done well and those innovations who have still the potential to do well, if they can actually convert it into the impact together, that is something we are hoping because why is this the need of such a platform? Because right now the system is not exactly what we all want together. The system is not as, I would say uh, in entry points as open as we would all like to be. There are behavioral issues, there are procurement issues that NHRC, doctor mentioned. There are several other issues. The platform will work with identifying the gap, will work with the larger plan, will build the implement, will build the evidence, and advocate for a systemic integration. And that is really, really important. So I took the question and I went somewhere else. But nonetheless, I was saying that the persistence, I'm saying, if you see from one of the most breakthrough, laughable ideas, just because of persistence, sheer competence, you can't take that away.
Yeah.
But I think without persistence, the success hasn't come through. You need everything, but on top of it, persistence. And that is something our partnership, we are hoping, while we may not know, and if I may a little bit counter Neeraj on it, while we not know the success of it fully, we do know that the cause is real, the need is real, the intent is real, and we want to do it together and with many others. That we want to make that change that we all think is much needed on the ground.
Can I just add?
Please.
Sorry, Ritesh. Just to. So I must say that I've been with Path for 7 years, and I can tell you there are a lot of innovators out there who actually hate us. They hate us because we come up and say, you know what, this is not going to work. You know what, this can't be scaled up. You're just wasting your time. And they come back and say, but hello, I've got funding from X. Why? I won't call them out because they're mostly all in the room. But, you know, they will say, I've got funding from this organization, this organization, this organization. You're the first person who's told me this is not going to work. I think overfunding also is a problem.
Yeah.
That's a huge challenge with a lot of the innovators because they're getting all these little pieces of money, but they're not getting the real truth. What is actually going to work? How are you going to put it together? How is it all going to come together? What is the connect with the public health system? What does Ministry of Health have to do with it? NHSRC. There are lots of stakeholders. There is a PIP. I don't know if everybody in this room understands what a PIP is, but it's a program implementation plan. Unless it goes into that system, there's no money. The government's not going to buy. So all of those things need to come together. So I think with innovators, I think innovations very important to be transparent upfront, to really sort of say what it is, say what's going to work, what's not going to work, and then move forward. And so, yeah, I mean, my team will probably hate me, but for all of you donors out there, don't give too much money. Just keep it tight, small bites. Yeah.
And I just want to build on what you said because I'm an entrepreneur myself. And at the start of my entrepreneurial journey, there were like literally two types of entrepreneurs I saw. The ones who knew where the case study competitions were happening, once you were getting the awards, the ones because all of these are, it's like a dose that you have to not feel the pain, right? Because going on the ground and selling is messy, right? So when you go on the ground, you feel like, oh, this is not at all working. It's much easier to sit in a room like this and say, maybe my idea is completely valid because everybody is telling me so, right? Except for the guy who's using it or the person who's using it. So building on what both of you said, I think the reality check has to be as soon as possible. But I want to pick on that public health system question a little bit, right? Because as you rightly said today, and at least my experience over the last 4-5 years is that the entrepreneurial energy and talent in healthcare has actually grown significantly. Many more people are interested in solving this problem, but we are sort of creating such a steep slope for them that it's like, you really have to be Bahubali to be able to get to the other side, right? Now, is there a way for regular people like me who are not like Bahubalis to also succeed? And that requires change in the health system. How are you thinking about that? One is to enable the entrepreneur, but how are we looking at improving, easing, enabling pathways for entrepreneurs in the public health system? Since it's a complex question, I'm going to start with Neeraj and I'm going to come.
Nasty, man. When Samir told me that you're going to be moderating this panel, I was resigning from the panel, but he forced me to come on because I know how good you are. Yeah, so I think the public health system is a big maze, and how do you get in? How do you work around it, etc., etc. I think Shishendu is still struggling to figure it out, though he's part of the system. But having said that, with the creation, especially I'll talk about digital, with the creation of Ayushman Bharat Digital Mission, with the whole idea of open APIs, the health stack, etc., the government has kind of opened it up and said, the small guy can also come in, the big person can also come in, and you can connect into the system. Will it get them a lot of money day one? Probably not. But you do have that opportunity. You don't have to be a Google. Is there Google in the room? Or a Facebook or Meta or any of those guys to get in. You can be a small digital entrepreneur who comes in, connects into that ABDM system, gets into the system, and maybe operates on a very localized, hyper local basis. So that opportunity has been created. Is it easy? Not yet. There are still lots of sort of hurdles. It's still building as we speak. But I would say that this is the right time to be able to do this. The only thing I wanna throw out at all of you here is that a lot of people in the digital ecosystem are kind of thinking, okay, I will get into this system, I will get access to a lot of data, and I will monetize that data. Now that's a dangerous game. I would just call out to all of us that this is not a data game. This is not about monetizing data, right? So we have to be very, very clear. We are here to build a health system which is going to deliver, which is going to create equity, and just make sure that you're not obsessed about data because you're not getting it. That I can assure you.
Absolutely, yeah. And I think it's only going to get with the PDP bill being discussed and all of that. The constraints and the rails around how we use data is going to be a critical factor for most startups who are sort of thinking of that as a secret sauce. And I think we are all moving to a place where democratic data access in some form at population scale is the way we'll all win, right? I'm going off script and asking you a question, a difficult question for you, right? One of my learnings having worked with startups is that you look great in the lab, look great in the pilot, and then you go to raise investments or you go to the government, they're saying, why is a critical mass deployment? But that's a chicken and egg problem. You're not proven, so you will not get critical mass. You don't have critical mass, you'll never get proven, right? And there have been ideas like a sandbox. There have been ideas like, listen, can we get them to show that evidence to make it work? In your partnership, how do you see that happen? Because for me, that is one of the most critical steps to enable a startup because otherwise they get stuck in the lab. How are you thinking about it?
No, it's a very good question and not as easy, but I think something that we have looked at together with Path and individually at CCAM as well is to closely work with practitioners and constantly also hear from them, public health practitioners, public health implementation agencies, be it the health at the state level, health departments, health commissioner, national health mission directors, and the entire team, and the all nodal officers who are there, is including the central. When actually when you are engaging much with them and you are hearing their needs, you actually identify some of them are very progressive in nature in terms of what they want to do. They may not have exactly the opportunity to do something. And here is your opportunity to tap on that and say, by the way, what you are thinking, we have something going on. Can we build an early evidence generation, study together? And those studies have been tremendously helpful in those where your chicken and egg is there. You're not trying to prove them at the big scale, but you have something who is opening up and giving that opportunity to do that. And we have seen in very like Karnataka, a few of the districts, but they have opened up saying, this district, I want to really do an impactful work. Right now, Tata, if you remember, if you know, Tata has started two large programs during COVID. One is diagnostics, but one is healthcare delivery, and they are adopting district after district in converting entire e-health data under their thing. So now here we are getting opportunity to build quick studies, either with medical hospitals, with them, but with the guidance of the state government. And that has been very meaningful. But to answer your thing, the Systems like us have to constantly understand the need for such thing, generate capability of that, have it built, deliver, so the potential that we are talking about gets to move forward. Otherwise, it gets stuck. And we have seen that those engagements have been phenomenally helpful in taking those cases forward. Where people are asking a larger question, they are stuck here. But if you build smaller steps for them by your engagements in the other systems, it has been very helpful.
No, thank you for sharing that. And I was in a conversation 2 days ago on agriculture, where actually one of the partners we are working with is institutionalizing an approach of a sandbox, working with states. So any new innovation goes through that. And as part of your partnership, again, unsolicited suggestion, is to sort of create some sandboxes like this that create a pipeline of innovations that can be tried in a certain meaningful scale and then being able to go. And once you do it in a few states, I think it'll become a lot easier for you to do it. Last question, because they're going to walk out anyway if you don't stop now. So, what will you talked about 1 year, and say, let's say 1 year, and meet you again in 3 years. What would success look like for both of you of this partnership?
So, Ratish, on script is dangerous. Ratish, off script is very dangerous. I must admit. Just quickly before I come to success, I think one of the important things about this partnership is that, you talked about a value of death. This is the first value of death for an innovator. As soon as they start talking to us, you know, they're going to realize that a lot of stuff is just going to get thrown out because we will be already sort of feeding into that. The other thing is, as we expand, one of the things that for public health is required is what we call pilot at scale. So, for example, when we did the private sector engagement project for TB in Mumbai, it was all wards of Mumbai. So that was the pilot. The entire slum population of Mumbai was covered under that pilot. But then that's the pilot that got scaled up. That's what went across the country. So you will have to do it at scale. So, we already, I mean, we have programs. We have a district approach in Satara in Maharashtra. We have multiple cities supported by USAID, 11 cities where we are working on primary health care. So, all those platforms exist. And a lot of the people, most of them have left, all the country directors have left, but Japaico, for example, IPE, Clinton, PCI, they all have these platforms.
Correct.
So
Absolutely.
you will have to do it at scale. Coming to your question before lunch, what would success look like? For me, if we are able to at least 2 or 3 solutions, we are able to run them at scale. And comprehensive solutions, not like what Prashant, not like your is he still there? Has he left? But not just a screening of chest X-rays, but a comprehensive solution. If we are able to do 2 or 3 in 2 or 3 geographies and figure out, learn, get them ready for scale, man, we're going to have a party next year. And Ritesh, all expenses paid, we're going to get you here.
Thank you so much.
So, no, Ratish, very good, and it makes us think as well. So, in addition to what Neeraj said about, you know, that, you know, pilot at scale, I would say that what are the areas that really we want to make change early in? We believe areas like maternal child health is a huge area that India needs to look at and look at, immediately to make changes. And if you see the entire continuum there are so many interventions can be built. So we want to pick areas and start building models for intervention which can make the change. So MCH is one, MNCH is one. The major other larger pandemic that's happening in India is NCDs. Non-communicable disease is going through the roof. If we can actually build capability to pick them early, screen them early, and intervene early, that's a great another opportunity for us to actually build a case for that to be deployed at scale. Third, very important thing that we all know about infectious disease and AMR. That's a huge pandemic right outside. Again, many smart digital interventions can actually minimize the projected damage that society may actually have if we can intervene early by this digital
Absolutely.
tools. So in this kind of areas, if we can start have the models and templates that we demonstrate, but this can be early stages, which will change. This will not be final templates, but if we can demonstrate templates in selected geographies where scale, the scale of impact and the deployment happens, that will be one large success, the change that we are trying to see, according to me, together with Path and CCAM.
And I am super, what you're calling solutions, what you're calling templates is honestly what I'm super excited about as well. Because it'll not just be the fact that these solutions are working, but this paradigm of thinking them as a set of solutions to solve a problem, and hence designing the system for that, I think is going to be, fundamentally transformative. Because I think we over-invest in one solution, we under-invest in the combination. And I think being able to get the combination right, I think is going to have significant value. Personally, as somebody who cares about this ecosystem, I'm super excited both of you coming together. And it is one of those things where the partners are right, the timing is right, and the problem is large, right? So all the very best. I hope to see you again, all expenses paid next year, where we have a much more happier news. And thank you everybody who's joined us as part of this chat.
Thank you. Thank you so much.
Thank you, Ratish, Neeraj, and Dr. Saeed, for a thought provoking discussion on the foundations for this collaboration, key considerations for the next 5 years, and where such a platform will and can take us. I'd now like to invite Varun Kumar Chauhan, Senior Program Officer, Digital Health, PATH, to deliver the vote of thanks.
So it has been slightly longer than we expected. So thank you for bearing with us, first of all. I'll not try to take more time. I want to relieve you as Neeraj just requested. So starting off, so I think on behalf of CCAMP and PATH, both these organizations, we have a lot of dignitaries present with us. Some have already left, but then I would still take the pleasure of extending our heartiest gratitude for being here. It was only through your presence here that we could learn so much. We've heard a lot of new ideas, and I think we'll go back with the learning today, and it'll be a good night's sleep where we'll be thinking about more innovations. So, thank you for enlightening us. Your valuable insights are really appreciated. Next in line, I would like to thank the audience here. Thanks for accepting our invitations to come. Some of you have also brought in your colleagues. So thank you so much for this August gathering. It was your presence and contribution here, I think, which is going to build this platform, the collaboration that we are looking up to. And thanks so much again for being here. Then finally, I will also mention a thanks for Anhat for bearing with us through this dynamic event. There have been a lot of changes through the script over and over. So really thanking her for being with us and then making this a success. And finally, the entire organizing team with me, that includes PATH, CCAMP, and our event organizers. Thanks a lot again. Wish you a wonderful rest of the day. And I think we can proceed towards lunch, which is served right behind you. So thanks a lot.